Good morning, everyone. Thank you for attending the Healthicity Auditing presentation, Providers and Critical Care, a Potentially Dangerous Love Story. My name is Amanda O'Brien, and I will be our facilitator today. A couple of items to mention before we begin. Today's webinar will be about 40 minutes, then followed by a Q&A session. Your line is muted, so if you have questions, please send them via the chat box or feel free to email your questions after the presentation. Please note there will not be any CEUs for today's webinar. Our presenter today is Layman Willis. Layman is a healthcare professional with more than 20 years of experience in hospital and physician revenue cycle, practice management, compliance, coding, billing, and client services. He has been providing healthcare consulting and solution services to hospitals and physician organizations throughout the country. With that said, I'll turn the time over to Layman.
Thank you, Amanda. Welcome, everyone. Glad you're able to attend our presentation today. As we get started, let me just cover what we're going to be going through in our agenda. We'll be looking at some case studies. We'll also be looking at the different definitions for critical care as they come from CPT, Medicare. We'll talk about some issues related to critical care and E&M visits themselves. Look at some documentation requirements. Talk about some tips related to some of those things and how we can benefit from those better. Also discuss some examples of critical and non-critical care services and think about what those might look like in your organization. Discuss issues around split share services. We'll summarize everything and then have some time hopefully for questions at the end that I might be able to answer for you. Please keep in mind the presentation is very informative. There's going to be a lot of information in here that will probably cover many of your questions. However, any that you do have at the end, we'll be glad to try to deal with those as we have time. So let's go ahead and get started. And so the first thing we want to talk about is just what we see in the CPT guidelines as it relates to the definitions for critical care. We're going to be talking about adult critical care, not pediatric critical care, by the way. And so from the CPT guidelines, we have this information that you see here, that a critical care service is something related to a illness or injury, in which it's a critical illness or injury, that impairs one or more vital organ systems, and it does so in such a way that there is a high probability from the physician's perspective of an imminent or life-threatening deterioration in the patient's condition. And so that's something to keep in mind. As it relates to how you provide, your providers are doing critical care, documenting that information, and how you go about doing the coding of that. These are all things that should be discussed with your physician so that you can have a better understanding of what actually critical care is, as opposed to patients who, are quite ill, are extremely injured, impaired, but they might not be critical. And so those are things to discuss with providers to have more definitive diagnosis definitions as well to kind of help with that. Critical care also involves a high complexity of decision making to assess, manipulate, support any of those systems or functions, to treat single or multiple organ system failure, to prevent further life-threatening deterioration of the patient's condition. Again, so some of this actually may be preventative to stop what would occur in the event that the patient would begin to crash, so to speak, in their vitals, in their organ system, in their failure to be able to thrive, as it were. And so critical care is also something that, according to CPT, can be provided on multiple days, even if no changes are made in the treatment that's being provided to that patient, or the patient's condition continues to require the level of attention that we've previously been discussing there as outlined in CPT. Now, although critical care typically requires interpretation of a lot of different physiological parameters, and there's application of advanced technology many times. Critical care may be provided in life-threatening situations when those elements are actually not present. And so, for example, just because you don't see CPR, just because the patient might not be intubated, things like that that commonly occur in the emergency department, for example. Just because that's happening, that doesn't mean that critical care isn't actually occurring. And so it's up to the physician to provide the proper documentation so that everyone is aware of those different things that meet critically ill or injured in the case of patients as they're seen. Now, providing medical care to the critically ill, injured, or a post-operative patient qualifies as critical care services only if both the illness or the injury and the treatment being provided meet those requirements that we went over. So that's what CPT states. Both of those have to occur. That the illness, injury, treatment being provided meet those requirements as to the critical nature of the patient. So codes 99291 and 99292 are used to report those for the duration of time spent in the provision of these critical care services to someone who's either critically ill or injured, and that time that is being spent provided to them on the date that it does not have to be continuous. For any given period of time spent providing critical care services, the individual must devote his or her full attention to the patient and cannot provide services to any other patient during that same time period. So that criteria is pretty well known. It's a standard that everyone is usually familiar with who's assigning codes for these services. The physician who's going to document time for this cannot be providing care to someone else at the same time that they're trying to take account for critical care services to a patient. Time spent with the individual patient has to be recorded in the patient's record, and that time that can be reported as critical care is the time spent that's engaged in work directly related to that patient's care, whether that time was spent at the immediate bedside or elsewhere on the floor or unit. And so you see in the example here that time spent on the unit or at a nursing station, on the floor reviewing test results or imaging studies, discussing the critically ill patient's care with other medical staff, or documenting critical care services in the medical record would be reported as critical care even though it does not occur at the bedside. Okay, and this is by the CPT definitions again. I just want to keep that in mind. Also, when the patient is unable or lacks capacity to participate in discussions, time spent on the floor or unit with the family members or any surrogates who are decision makers for obtaining medical history, reviewing the patient's condition or prognosis, or discussing treatment or limitations of treatment may be reported as critical care provided that the conversation bears directly on the management of the patient. So that really means that your documentation has to support that. It shouldn't just say, discussed discussed history with the family. You need to document what the history was that was discussed, or concerning the prognosis, what the prognosis actually is, and what the expectations might be, or any type of limitations. Those need to be detailed out in the documentation of the patient's record. Now, time spent in activities that occur outside of the unit or off the floor, whether those be calls, taken at home or in the office or elsewhere in the hospital, those cannot be reported as critical care since the individual is not immediately available to the patient. And so that makes sense, obviously. You want someone there close by who's providing this care to the patient. The time spent in activities that do not directly contribute to the treatment of the patient may not be reported as critical care, even if they are performed in a critical care unit, such as participation in administrative meetings or telephone calls to discuss other patients. you can't count that as critical care if it's not directly attributable to the treatment of that particular patient. All right, and then time spent performing separately reportable procedures or services should not be included in the time reported as critical care time. That really should say something to us about some of those services that occur during that critical care time period, right? That really means that those procedures, we should know how much time those procedures took to take place, and that the critical care that has been documented, that time that the physician wants to take credit for 99291 and 99292, they should not be inclusive of any of those other procedures that would be separately reportable and services that should not be included in this time. All right, so code 99291 is used to report the first 30 to 74 minutes of critical care on any given date. It should be used only once per date, even if the time spent by the individual is not continuous on that particular date of service. And any critical care that is less than 30 minutes, a total duration on a given day, should be reported with another appropriate E&M code. Code 99292 is used to report the additional blocks of time that are beyond the first 74 minutes, excuse me. And so anything beyond the first 74 minutes is going to be reported with 99292. And we'll cover that more as we go through. But you kind of see a chart, and I believe that these are found not just in CPT, they are found in the CPT guidelines, but you can also find these at various websites. Medicare has them as well posted, but it's just a kind of a handy tool to have on hand to take a look at, something to go over with your coding staff and providers for them to have as appropriate information and illustration for them. All right, so next we're going to talk about Medicare adult critical care definitions and see if there are any nuances or differences between specifically what CPT is going to talk about and what Medicare will get into in relation to the guidelines that they provide within various online internet manuals and things like that. So the first thing is that the critical illness or injury acutely impairs, again, one or more vital systems. There's a high probability of imminent life-threatening deterioration of the patient's condition. So there's no real change as compared to CPT in these statements. These are essentially identical. This critical care involves the same type of high complexity decision-making acts to assess, manipulate, support those systems or single or multiple vital organ systems that are failing, or to prevent further life-threatening deterioration of those patients' conditions or injuries, whatever it might be. And it requires, though, direct personal management by the physician. So there are some statements that CMS has to kind of really point you to what they're talking about and what they're looking at. It requires direct personal management by the physician, requires frequent personal assessment by the physician. And so those kind of statements you don't really see in CPT, but these are specific to Medicare, and it just lends itself to obviously what would be occurring with a critically ill or injured patient anyway, that this physician would or should be doing that, right? And so this just kind of speaks to that. Now, one of the things that Medicare does point out is that critically ill does not equal critical care. It must be medically necessary. It must meet critical care definition. And I'll talk more about what that means in relation to Medicare's ideas about that, what their guidelines and their regulatory information states about that. But that's something to really keep in mind. Critically ill does not equal critical care. Right? So one of the first things is critical care time reporting. The physician must devote their full attention to the patient. That must be recorded in time in the medical record, and that critical care time is time spent at the bedside or elsewhere on the floor unit. Okay, it can be any of those areas. The critical care family discussions, this is included in the pre and post service work. Routine daily updates or reports to family members are considered part of this service, which means that these cannot be counted toward critical care time. Now that's different from CPT. CPT does not have that spelled out that way in relation to these codes. However, Medicare does. And so they consider these things to be pre and post critical care, right? They're part of that code. What you're doing before, what you're doing after, and those follow-up reports with the family about what's going on with the patient are considered part of that, and that's not something that you're going to count, excuse me, extra. You're not going to include that in your critical care time. All right? Count time spent with the patient's family when the patient is unable to participate in giving a history or making treatment decisions. When you need to discuss anything that's necessary for determining the treatment decisions for the patient at all. All right? And so all other family discussions, no matter how lengthy, cannot be counted toward critical care for Medicare purposes. And so it's kind of short and sweet. It's really spelled out, good for you to be able to know that. And it really means that you have to pay attention as far as your payer when you're assigning your critical care codes and how you go about doing that. Or you might consider having a policy and procedure which really covers everyone in one way as far as how you're going to do your coding, how you're going to assign those codes, that the physicians are on board with that, that you've got policies and procedures written up about that, and everyone is in agreement and knows what they're going to do as far as following those guidelines. All right, so now inappropriate time counted. Procedures not bundled into critical care, that time would not be counted. Time not involved should not be counted towards critical care. Other time that's being spent on the unit or floor, time that's outside of that unit or floor, excuse me, time that's outside the unit or floor. Medical records need to reflect the time that's involved of those separately billed procedures. And I spoke about that in relation to the CPT definition as well. And then teaching sessions with residents, even when bedside, that information is inappropriate as far as time that's going to be counted for your critical care services. All right, things that do not meet the criteria for critical care. Patients who are admitted to a critical care unit due to various hospital rules regarding certain treatments. You may have some type of protocol in which patients go to the critical care unit to have certain types of procedures provided. You know, it may have always been that way, or it may be easier as far as processes or billing or whatever it might be. However, just because that patient goes there and has a service provided does not mean that that's critical care. Daily management of a patient who's on ventilator therapy does not meet the criteria for critical care definition, and so you cannot report that way. All right, again, Medicare, the same type of principles are appropriate as it relates to the kind of the guideline, the chart that you see here, in what they're going to consider critical care services, the 99291, 99292. Anything less than that, you're going to use a particular subsequent hospital care code or some other appropriate E&M service. So maybe it might be an emergency department E&M services if it's provided there in the ER. So that will just depend on, of course, you know, where the service is taking place and in the facility or whatever place that happens to be. Medicare has some bundled services, of course, as well as things that are kind of spelled out in CPT, but I kind of put them here they're well known by those who are coding for these services. If you're not someone who has done this routinely, or this might be new to you, then these are things to take a look at and to understand. These items are bundled into critical care, so they're not reported separately. They don't get billed for and, reimbursed for separately. All right, so we're going to talk about E&M visits, critical care and E&M visits for a moment. And as we do that, one of the things to consider is, of course, the area of the emergency department. The emergency room and critical care, these are where a lot of these type of services will obviously occur. Patients arrive there, they're in some type of distress, or they have an injury, something is going on with them. If there's an appropriate ER code that exists and the standard of care can be reasonably provided within those codes, then those are the codes that should be utilized by the ER physician. However, if the nature of the patient, their condition or their injury, whatever it might be, meets the definition of critical care, then only the critical care code should be billed, not both. You don't bill for critical care 99291 and an emergency department E&M code 99282 through 85. So you don't bill for both. You can only bill for one of those from one physician. So keep that in mind. That's information that's sometimes found in denials and certain peer reports, some of the reporting mechanisms from the MACs and things like that, the CERT reports. And so you'll find things like that as they get reported inappropriately and in an error. They have to do with things like this and reporting the wrong code set together. An example here, cardiologist might be called to the ER to assume responsibility for a patient, provides critical care services, and may bill a 99291. The patient stabilizes and transferred to the critical care unit. All right, and so you get to report that code. You don't report both. You report one. Hospital visits and critical care same day. Physician sees an ill patient in the hospital early in the day. Later in the afternoon, a nurse practitioner from their group performs critical care on the same patient. So for appropriate level of E&M under this, one is going to be reported by the MD for their NPI, billing 99291 with modifier 25 under the NP's NPI. So you bill for the appropriate codes from each. The 25 gets reported on the 99291 for what has occurred in that service, which is separate. Okay, for those global periods, critical care global periods, preoperative critical care may be paid in addition to global fee if the patient is critically ill and requires full attention of the physician. If the service is unrelated to specific anatomic injury or general surgical procedures performed, again, modifier 25 gets reported with the critical care code set. And then post-operative critical care may be paid as well. Documentation, again, has to support that information as it was unrelated to specific anatomic surgery that's performed. And modifier 24 would be reported on the code set as appropriate. And so, again, time spent performing the pre, intra, post-procedure work is excluded from the time spent providing critical care, as long as that has to do with something else, right? So you need to remember that time criteria and look over this information, be familiar with it so that you're able to properly assign your codes here. Right, critical care and concurrent care. It may be paid if it meets critical care criteria, if it's medically necessary, it's not duplicative, and generally of a different specialty, right? So examples, cardiologist versus endocrinologist. So, two separate specialties providing care to a patient. There can be concurrent care that's actually occurring here, critical care and concurrent care as well. So these are things to, again, consider that can happen. It can be two specialties that are actually happening that way, and getting to provide that service. All right. So now we're going to talk a little bit about some documentation requirements and some tips as it relates to that, specifically and especially as it relates to Medicare, because you're going to need to be aware of those. The critical and unstable nature of patients' conditions have to be documented to support medical necessity. And these are one-to-one services, right? And these are extended services. They're beyond that 30 minutes of time. Time is critical to be able to show that. The complexity of the medical decision making is something that needs to be spelled out in the documentation for the patient's care. The aggregation of time that's spent by the billing provider needs to be in there. If it's not properly notated, it needs to be cataloged somewhere, categorized, and then any of those procedure times as well need to be documented too, because they cannot be part of that critical care time. Patient assessment, information related to that is key. The family discussions that occur that are related to their treatment as they're critically ill or injured, it has to be substantive information. It needs to be detailed in what has been provided to those in conjunction with those family members concerning that patient. And then the total time spent, that is the key component for all of this, is time, right? It's that time factor. Now, it's important to note that the documentation has to match the complexity of the medical decision making as well as the time spent in critical care, exclusive of time spent during any invasive diagnostic or therapeutic procedures. And those would include things like intubation, bronchoscopy, cardioversion, thoracostomies, central venous lines, things like that. That documentation has to show that just because these things might have occurred, it doesn't necessarily mean it meets the level of critical care. You have to discuss that. That has to be well detailed in order for that to be appropriate. So some of the failures that are commonly seen as it relates to critical care services is, of course, documentation that simply doesn't provide the level of service, right? So it's missing the time. It lacks the detail of the information for the inclusiveness of all of the time that's included, or it's less than 30 minutes. Signatures might be lacking, or they might be illegible or invalid. And so those are most notable, of course, when you'll find those in the electronic format. There's no medical necessity, possibly, that has been provided. And so that could possibly occur up on the floor of a hospital somewhere in which a physician is trying to take credit for critical care services, but there's no medical necessity for that that's being provided. There could be missing or insufficient documentation. It's just simply not part of the record as it's being audited. And then, of course, again, that total amount of care, critical care time that's been spent on that patient for that date. All right, next are some examples of critical care versus non-critical care services. And so these are examples of things that would usually be considered critical care. However, again, everything has to meet the criteria. Just not the statement itself is going to, carry the level of it all. But again, when someone is in failure of their organ systems, these are the things that are usually going to end up that a physician is providing critical care services to someone when they're having a failure of any of their organs in this way. Commonly people think about respiratory failure, but they don't often maybe think about metabolic failure, right? Or the patient may have shock-like conditions. They might have an overwhelming infection. And so those things are key to discuss and talk about with your providers who are doing critical care services, to think about what that documentation looks like in the record, and maybe have some mock coding scenarios where you code those out and you look at those and you say to the physician, is this critical care or no? What level of care does this rise to? Things that have complications that are post-operative complications. Again, all of those might be examples of critical care services if the other criteria obviously is all met. Now, examples of non-critical care services are, as previously mentioned, some things that might actually happen in the ICU with a patient who, just because they're in ICU doesn't mean that they're going to have a critical care service provided to them. So in this case, a dermatologist is treating a rash on a patient who is in ICU, who's being maintained on a ventilator and a nitro drip, who's being managed by another physician who's an intensivist. And so in this case, the dermatologist is simply going to report the proper E&M code for this and not a critical care code. All right, let's think about a few case studies, and there are many of these type of examples that you can go out and find on various CMS websites, probably also some at your MAC websites, depending on who that is. But these are just some examples that I came up with for our discussion today. Two physicians, same specialty. Dr. Howe, an ED physician, performs 40 minutes of critical care on a patient who arrives in the emergency room in cardiac arrest. Dr. Yan, a cardiologist, is called in, assumes care, provides 35 minutes of critical care, stabilizes the patient, and the patient is moved to the ICU. So based upon, of course, all the criteria that would need to be met, assuming that that has occurred appropriately, Dr. Howe and Dr. Yan both are eligible to bill 99291. All right, a 68-year-old male is admitted for right lower lobe pneumococcal pneumonia with a history of COPD. They become hypoxic, hypotensive 2 days after admission. Dr. Addis, who's a pulmonologist, performs 40 minutes of critical care in the AM. Dr. Mangia, a pulmonologist, the same practice, performs 25 minutes of critical care later in the day. And so what's going to happen with this? 99291 times 1 combined time, since it's under the 74 minutes, you use either physician's NPI, but it must be a single physician billing for both codes. All right, another example, 71-year-old female is admitted for acute anterior wall myocardial infarction. They continue to have symptomatic ventricular tachycardia that's marginally responsive to antiarrhythmic therapy. And so in this case, two physicians, different specialty, Dr. James, a pulmonologist, Dr. Sheridan, a cardiologist. One performs 45 minutes of critical care. The other performs 40 minutes of critical care. Dr. James is going to bill a 99291. Dr. Sheridan could bill either a 99291 or 99292, as long as the services are not duplicative, not a covering or staff physician. Okay? And again, two physicians, same specialty, different practice. Dr. Cantor, pulmonologist, performs 40 minutes of critical care. Dr. Tannen, a pulmonologist, different practice, performs 50 minutes of critical care. Again, both are eligible to bill for 99291, assuming that everything meets the criteria. All right, so now momentarily let's think about The issues as it relates to split share services. And this is where some people will obviously begin to realize the importance of knowing about this information, as opposed to in other scenarios where you're able to report and be paid for split shared services. We need to think about in the critical care area what that means. So split share E&M service performed by a physician and a qualified non-physician practitioner of the same group practice cannot be reported as a critical care service. So it does not qualify. Critical care does not qualify for split share billing, right? So that's something to keep in mind. While that can occur and does occur for other types of E&M services and is totally legitimate, for critical care services, it is not. The critical care codes reflect the evaluation, treatment, and management of patients by an individual physician or a non-physician practitioner, and should not be representative of a combined service between a physician and a qualified NPP. So again, no split share on these. So when the time requirements for both 99291 and 99292 and critical care criteria are met for a medically necessary visit by a qualified NPP, then the service would be billed using their appropriate individual national provider ID number, right? So, you know, it's going to be either or. If the physician did it, you report it under the physician. If the NPP does it, you do it under the physician. You can't do both. You can't share it together with these individual types of providers. So it's one or the other. So an example here of a medical doctor and the non-physician practitioner, Dr. Brown, cardiologist, performs 45 minutes of critical care. NPP, same group, performs 35 minutes of critical care. They both can report 99291. They're not sharing, right? They both are eligible to provide that service and perform that service. And so, again, just remember that staff coverage or follow-up after first hour of NPP may bill the 99292. So again, this is something to keep in mind. Don't share it. Don't try to split it or share it. So we're going to begin to just think about wrapping things up. We'll summarize a little bit, have some time for some questions, and hopefully this has answered most of those, but we'll try to cover any that you might have. So as it relates to split share, of course, the split shared services are not allowed for critical care. It's reflective of the care of a single provider. Only one provider can bill for any single time period. Documentation of focus time spent on the patient can be continuous or intermittent in aggregate time increments over a given calendar date. It's got to meet the time minimum minute requirements. And critical care is based on the patient's condition, not the patient's location, right? Based on their condition and not the patient's location. And you would want to put together, again, some policies and procedures around this. You would want to think about some different scenarios, probably even some redacted records could be part of that policy and procedure for training of other people within your organization. Your providers could probably help come up with some different records to talk about and think about as it relates to critical care. I recommend going over those ones that I mentioned previously that might be like a metabolic failure, you know, when patients are in shock, things like that, when the provider is providing critical care services to those patients, okay? And so again, make those part of your plan of your coding, your audit plan, you know, discuss those with providers, have policies and procedures on hand, make sure that you're aware of the nuances and difference between the CPT definitions and CMS's definitions as it relates to critical care services and how those services should be reported, the breakout of time spent providing procedures, whether they're diagnostic or therapeutic, to patients as opposed to the critical care time itself, what might be included as far as pre and post in the global context of that code for Medicare. All right, so all of those things, you need to consider those with your policy, consider those with your training, and go over that information with your staff so that everyone is well aware of the details of that, okay? So with that said, I believe it's time for some questions now at this point. And so I'll turn the slide presentation back over to Amanda, and we'll take some questions at this time if we have any.
Sure. Hi, Lehman. We do have some questions for you in your question box.
Okay, so the first one is, let's see, my provider would like to charge critical care for a combative patient who is in 4-point restraints as a patient, is not critically ill. I cannot justify reporting critical care. What are your thoughts? So if the patient is not critically ill or injured, you cannot report critical care services, regardless of what your provider may want to do. As opposed to their E&M code, there may be another E&M code they could use. That there could be some things that are helpful with getting the proper E&M level as it relates to not being able to get a thorough history of the patient because of their condition or whatever it might be. Those are things, again, policy decisions you'll need to discuss with them and also consider what those might be with your payers. But you can't use critical care for something like that. Okay? Let's see, what else do we have here? Define covering or staffing physician, please. All right, so on the staffing, the coverage staff, I'm going to have to relate that. I'll have to get back to everyone on that as far as a follow-up question that we'll post on our website for those. There's some details that will need to be provided as it relates to that. All right, let's see what other questions we might have. Hold on just a minute and let me look over these. All right, does the physician have to make a statement in critical care notes as to why the patient needs critical care? No, the physician does not have to do that. They don't have to make a statement as to why. What they have to do is document in there showing the patient's condition, right? So it doesn't have to be a statement as to why they need it. It just has to be the condition of the patient that shows that they are critically ill or injured. And that information would need to meet, obviously, the definitions of critical care, as we already went over. That those definitions relate to, failure, organ system failure. It's such that it is believed that there's going to be failure. It's life-threatening to the patient or it's limb-threatening to the patient. Those type of things within the documentation are already what are meeting the definitions of why the patient needs critical care and what they would meet for that. All right, let me see another one I can find here. Patient presents to hospital, acute respiratory failure. Patient stabilized on vent, sent to ICU. Can a pulmonologist bill for critical care for managing the vent and IV medications? Patient is stable only because they're on the vent and IV drip medication. So let's see. Let me just look over that for just a second. So if the pulmonologist is the one who has provided the critical care service to the patient, the pulmonologist should be the one to bill for it. If it was someone else who stabilized the patient prior to that, then the pulmonologist is not going to be the one that's going to bill for the critical care service. They're billing for after the fact, not for the critical care itself. All right, another one, patient has bleeding or hypertension during surgery. My doctor sends the patient to intensive unit. Can the doctor take care of patient bill for critical care? That's kind of an unknown. You know, that doesn't really, that's not enough information for me to really say. That would be, again, based upon all the information, excuse me, that the physician is going to provide in there. If the physician believes that without that intervention, that treatment, uh, that the patient is likely to have some type of organ failure, system failure, is their life is at threat, their limbs are at threat, then they should document everything that they would need for critical care services to bill for that. All right, should exact time be recorded, such as 36 minutes versus over 30 minutes spent? Absolutely. You need to have that detail to be able to know how many units later you might be able to bill beyond that 74, of course, if you needed to bill 99292, as well as 99291. So you'll need to know the details of all of the minutes that would be, you know, aggregated. So as it relates to 30 to 74, not so much, but beyond that, of course, you would need to know it, right? So, you know, it's a minimum of 30 to 74 for the 99291, and then, excuse me, beyond that, you'll have various, you know, levels that you'll be able to report that 99292 for. All right, so what constitutes ventilator management only? Ventilator management is specifically outlined in CPT. I'll just have to ask you to look up CPT code for that, the guidelines related to that code as it pertains to what is going to be inclusive of that service. There are some different things that are occurring with that. The patient is on a ventilator, right? So there are things to do with hooking them up, taking them off, you know, the monitoring and management of them while they're on it. But just because they're on one doesn't mean they're critically ill, or that can be reported that way. Let me see if I find another one. So if an intensivist caring for a patient in ICU has a patient who meets the definition of critical care, and you also have a cardiologist caring for the patient, treating the patient, can they both bill critical care? And what if they're caring for the patient at the same time? So yeah, if they're caring for the patient at the same time, and both of them are going to try to take credit for critical care services, they're of two different, you know, specialties. I would believe that they can. However, that's going to be one of those things where, you know, the documentation for that and an audit for that will really relate to what the payer believes and what the payer thinks as it relates to that and to providing the service at the same time. So that's going to be something, you know, left in the hands of your payer as far as the guidelines for that, something to really get into the weeds about with them and ask them, whoever your payer might be. All right, let me see if I can find another one. Let's see, when a physician provides critical care and then later the same day the patient passes away, can the provider bill for both critical care and a 99238 for pronouncement of death? I have to get back to you on that. I'm not quite sure on that. I'll have to do some research. We'll post the answer for that online at our website.
Hi, Layman. We have time for just one more question.
All right, let me find one more. All right, with palliative care provider meeting with the family to make a decision to take the patient off life support be considered critical care? Probably not. You know, this is This is end-of-life decisions. You're not trying to continue to save the life and extend the care of the patient and or save their vitals, right? So I do not believe that would meet the definitions for what payers are going to definitively ask for in critical care services, as well as CPT and CMS definitions as well. Again, that's from me, from what I just told you. That's just from me. That's my opinion. I don't know of any specific regulatory guidance one way or the other as relates to that question. So it's really something that you're going to need to probably do a little bit more research on, but I do not think that that would be the case. With that said, any questions that we did not get a chance to cover, we'll do our best to deal with and come out with a follow-up to our webinar and deal with those questions at that time. And so, Amanda, I'll turn it back over to you. Thank you, everyone, for attending today.
Thank you, Layman, for your presentation, and thank you, everyone, for attending today's webinar, Providers in Critical Care, A Potentially Dangerous Love Story. If you have any questions, please direct them to Layman Willis at layman.willis@healthicity.com. We will be emailing everyone in the next few business days with an on-demand recording of today's presentation, as well as a link to the slide deck where you can download it. So keep an eye out for that email. Thanks again for joining.